technically right and scientifically right. This is ideal healthcare. 70% of the healthcare is given by the private sector, and the vibrant private sector carries all the burden of health services. And it is very pertinent to note that small and medium private hospitals providing quality, affordable primary and secondary healthcare are an asset to the nation and not a liability. So when we say the small and medium hospital, I label them as friendly neighborhood nursing home, which are doctor owned, either a single doctor owned or a couple doctor owned or a family of doctor owning that hospital, which in technical term is called as own account enterprise, OAE. And this friendly neighborhood nursing home provides 24/7 affordable, ethical, accessible, accountable healthcare. Is very important. And unfortunately, today the status of small hospitals, they are facing existential crisis. That is why we are discussing this, the survival of the small and medium hospitals. In Kerala, more than 800 small hospitals have closed down in last 10 years. This is a study done by IMA Kerala State Branch. Just 6 months back, Pune IMA did a study. In 1 year, in the city of Pune, 30 doctor-owned hospitals, that is own account enterprises, closed down. And that is why fresh specialists are not starting individual hospitals. If you see the statistics, only 8% of the population lives in Tier 1 cities. Unfortunately, 85% of our healthcare facilities are present in these Tier 1 cities. Small hospitals which have less than 30 or 50 beds. And in India, 85% of the private sector establishment have less than 25 beds. Hence, the small hospitals constitute a vast majority of the healthcare space. If you'll see, as I said, 30% government setup, 70% private setup. And the private healthcare mainly consists of clinics and small hospitals. 90% is constituted by solo practitioners. If we'll see the Indian healthcare expenses overall, maybe from the patient or from the government side is 4 to 4.5% of the GDP. While the government spends for last 79 years only 1 to 1.5% of GDP. The rest comes from out-of-pocket expenditure from the patient. 72% of the healthcare expenditure is out-of-pocket. Healthcare expenditure share of families' budget ranges from 15 to 33%. And most important statistics which one needs to understand and make the community leaders and the policy makers understand that every year 3.3% of the population is pushed below poverty line in their attempt to provide for a family member who has fallen sick. So the medical expense constitute one of the major reasons for poverty in India, and this is not our own statistics. This is from the National Sample Survey Organization, NSSO. While this vibrant small and medium-sized hospitals were providing corporatization of healthcare. On one side, we saw own account enterprise, while the corporates are for-profit organization. This important difference one needs to know, that their main motive, which is there in their memorandum of understanding, memorandum of article, is to earn profit. So diminishing family physicians, small hospitals, aping of Western country models which are insurance based, and corporatization. As I have labeled the small and medium hospitals as friendly neighborhood nursing homes, I have labeled the corporate institutes as faceless medical malls, where the exploitation is not only of the patient but also of the doctors and also of the government. And if you will see, the private sector in India is estimated to be 13.67 lakh crores in the financial year 23. which is growing the CAGR, that is the growth rate, is 18.6%. Owning and operating hospitals in India is one of the most lucrative business today. All the foreign private equity firms are acquiring hospitals left, right. So a vast numbers of foreign and domestic investors
I can't hear. Is there some problem?
Because the profit margins are around 20%, they are investing into hospitals.
Dr. Pawan, go ahead.
Yes, sir. I
Is
can't
there
hear.
a hidden agenda? Yes,
there any problem?
definitely there is a hidden
Your
agenda.
side or my side?
Pressure from the corporates to capture this more than 12,000 crore market of healthcare. The government wants to come out of the public health infrastructure, so it is promoting privatization. It is killing individual entrepreneurship and to create underpaid, highly trained doctors to work as slaves in big hospital. This is nothing but a new East India company coming into the health sector. The medical equipment industry. We forget the role of the hidden agenda of the medical equipment industry. Small hospitals will not buy a cath lab. Small hospitals will not buy a new MRI machine. They will not buy a robotic surgical instrument, while these corporate hospitals will buy. So there is a pressure from this medical equipment industry also. So previously it was high touch, low tech. Now it is becoming no touch and high tech. What are the key challenges? Financial strain due to low occupancy, low revenue per bed. If you will see the average revenue per bed of corporate hospital is around 70 to 80,000. Just last month, Apollo Hospital came out and their each average revenue per bed is 72,000 rupees. Don't be surprised by this figure. It is there in their annual report. So each patient which gets admitted in any of the Apollo hospital, the hospital earns 72,000 rupees per day. The high fixed cost, the regulatory burden, will all be dealing this in slight detail later on. Competition from these large chains, cash flow issues due to reimbursement delays. We have seen in Haryana what has happened, and congratulations to Haryana to present a united front. You have difficulty in hiring and retaining specialists and the staff, infrastructure and branding limitations. Consumer Protection Act, information explosion, blatant privatization of medical education, multiple regulation, high cost, insurance model, mixopathy, violence, technological advances are some of the few challenges which is resulting in small hospitals on deathbed. The patients are facing increase in treatment cost. Doctors are entangled in paperwork. Treatment is because of violence. Treatment is done under constant fear, under the pressure of violence or legal cases. So a doctor today in a small hospital, individual hospital, always has a fear once the patient walks in, whether he will beat me or sue me. Ultimately, all this is affecting the patients. So what are the key challenges? The financial challenges, as I said, due to limited revenue, difficulty in procuring modern medical equipment, struggling to attract and retain the paramedical staff, insufficient funds for infrastructure upgrades, limited bed capacity, long waiting times, decreased quality of care, difficulty in maintaining patient privacy, higher risk of infection spreading. Staffing issues, there is shortage of trained staff. The Clinical Establishment Act on the one side says that you should have qualified staff. There are not enough qualified staff. Even if you try to hire, our costs go up. Infrastructure and technology constraints, as I said, supply chain problems in small mofussil areas. Even if you buy costly equipment, the servicing, the replacement, repairs are a issue. Regulatory compliance, I will come in detail on it. Competition from these large chains. Rural healthcare challenges present a totally different picture, where you need lot of basic issues of schooling for the kids, electricity issues, simple things. Insurance is a big problem. Emergency response and disaster preparedness for small hospitals is an issue. Patient trust and perception. Inadequate CME, we usually don't tend to upgrade our knowledge or what we call a sharpening of the axe. There are certain language and cultural barriers. We are not indulging into patient education and awareness. Maintenance of medical records for a small hospital is a big issue. As I said, electricity and infrastructure reliability is another issue. Community health outreach, legal and ethical concerns, I will come to it. As we see that whether patient care or office work, which I call it as whether a hospital owner is to do a clinical work or a clerical work. Friends, there are 73 laws governing a small hospital. If you are running a small hospitals, there will be laws regarding the institutions, laws regarding human resources, laws regarding professionals, laws regarding service delivery. So lot of laws, and to comply with these laws is one of the key challenges now faced by small and medium-sized hospitals. We feel, the healthcare providers feels that our sector is over-regulated, while the lawmakers and administrators paradoxically feel that the sector is unregulated. Hence, every day in, day out, we find new and newer regulations coming into the play. All these laws breed corruption. Let us be frank with it. Assaults, various types of assaults. A single doctor practicing in a Mofussil area, always under fear. The assaults are not only physical, they can be verbal, legal, administrative, mental, economic, cyberbullying, image damage. Every type of assault a doctor practicing with a small nursing home faces. Another key challenge is the ethical paradox. Own account enterprise. If Dr. Wankhedkar is running a nursing home, he is registered with the previous Medical Council of India and is governed by medical ethics. So I can't advertise. Say for example, while a for-profit organization, that is this faceless medical malls or corporate hospitals, they can advertise because they are not governed by professional ethics, they are governed by business ethics. They can give cuts and commissions for promotion of their business. So this ethical paradox is one big thing where there is no level playing field for a doctor-owned hospital or versus a for-profit organization. This is a very big challenge which we need to address on an association level. Insurance-based model is a failed model worldwide. Try to understand. Private insurance companies are for-profit organizations. If we'll see their annual report, the profit margin of health insurance companies in India is between 26 to 32%. So they are answerable to their shareholders to earn profit. So on one side, they decline claims from the patients, and from the healthcare providers or the hospitals, they expect low insurance packages. So insurance-based model or copying the Western model, and United States of America is a glaring example where it spends 17% of its GDP on healthcare, but it ranks 21st in all healthcare indices because it is an insurance-based model where everything is going into the pockets of the insurance company. So what are the survival strategies? See, empanelment under government schemes, they need to be improved. We need to focus and create niche specialties. I can give you my own example. I am a general surgeon. I was focusing on all types of surgery. When I saw that all multi-speciality hospitals are coming, last 15 years, I shifted to proctology. So proctology is my niche specialty and my earnings remain the same. Operational efficiency. You need to have shorter stays, daycare procedures. You need to use digitalization, forming hospital network and cooperatives. You can lease equipments, flexible staffing, and expanding outpatient and diagnostic services. We'll study this in detail. So adapting technology, digital tools, telemedicine, online booking, patient portals can attract tech-savvy patients and provide more efficient care. And these are not costly, my dear friends. Specializing in high demand, high margin services. So you shouldn't, and we can't compete with the corporate chains with their heavy financial backing. One should not really compete. One should rather focus and create our own space in this particular environment where we can have small hospitals can become centers of excellence, as I said, in niche areas. You can expand ancillary services, bringing in pharmacies, diagnostic, in-house diagnostics, which can account significant amount of your revenue. Artificial intelligence is coming in a big way. One needs to learn to use this particular new agent. It is not a tool. Discovery of wheel, discovery of computer was a tool. Artificial intelligence is an agent. It can think on itself. So it is going to revolutionize. So the future will be physicians with AI or physicians without AI. We need to learn to work side by side with AI, especially running a small hospital. You have to establish partnerships with local clinics. You can offer corporate health packages. You can provide outsourced diagnostic services, medical tourism, especially in borderline states. One of our friends in Jalandhar provides excellent medical tourism only for IVF services, and he is doing extremely well. You need to develop patient-centric and operational. You have to improve the patient experience and loyalty. The greatest plus point which we have as a small and medium-sized hospital is the good doctor-patient relationship and the trust. Because each and every patient comes with my name. Dr. Ravi Wankhedkar needs to operate to me. I have operated his family, so he comes to me. That trust, that level of doctor-patient relationship and trust, the corporate hospitals can never generate. You need to exploit maximally this particular aspect wherein the loyalty of your patients. So many of our gynecological nursing homes, they tell us that the grandmother delivered with them, then their daughter-in-law came. By the time daughter-in-law came for delivery, the grandmother's hysterectomy was done. So continuous families keep on coming. So you need to develop this loyalty. You can conduct camps for community outreach. You need to boost staff retention. Staffing is a big issue. We train a staff and for 1,000 rupees extra, he goes to another hospital. Or if we scold him, he leaves us. So one needs to have good human resource management. You can train your staff where role of Indian Medical Association comes into play. As I said, there needs to be smart specialization, sub-specialization. You need to brand your hospital. You need to use technology, create a website, create a brand. Cooperative networks. In Kerala, they have done a very successful model of cooperative hospitals where they have come together under the aegis of IMA Hospital Board of India. They have another organization, Small Hospital Owners Association. There they even do common procurement where then they can negotiate much better than individual hospital, including from bed sheets to hospital furniture to hospital equipment. They also have a common portal wherein staff can also be shared. You can create such a model, and in Kerala they are doing it successfully. Referral partnership, the David and Goliath model, you can partner with a big corporate chain and act as their satellite unit. Digital transformation. No need to buy very costly softwares. You can use the cloud-based services. You can offer telemedicine, digital marketing. A very strong digital presence can help in branding your own particular services. And as I said, patient first approach. This is the trump key which we hold with corporate hospitals. That is why I've labeled them as faceless medical malls. No one takes responsibility. While a patient coming to me, the entire responsibility is with Dr. Wankhedkar. And then that bond gets developed. We need to develop that bond through proper communication, through good documentation, through compassion. And that bond will yield higher returns. The policy changes, faster reimbursement mechanism. You need to have simplified regulatory compliance, financial incentives, tax breaks, and credit support. This is one of our persistent demands that as governments, various state governments or the central government gives lot of tax benefits, free land, subsidized land to various industries where there are no industries in the backward zones. Why not the government create such a same model which they give for the industries, for hospitals in the private sector? Suppose in a tribal area, in a remote area, if a surgeon wants to go, why don't they give them subsidized land? Why don't they give them tax break in income tax for 5 years? All this policy and support is the job of the association. See, the small and medium sized hospital market is expected to reach 5 trillion rupees by 2027. Growth is expected, but the margins will be under pressure. Critical role of SMEs in the healthcare ecosystems and our survival depends on the policy reforms and our own innovation. Here comes the role of association. As I said, association, and as you have demonstrated, and this is happening in so many towns and states where state insurance or the Ayushman Bharat insurance rates, their issues in reimbursement have been tackled by our association. The Indian Medical Association, now the government has come out with a regulation where they are going to fix rates. We have been tackling this issue since last 7 years. And we have done an extensive study for 4 states in Tier 4, Tier 3, Tier 2, Tier 1 cities and come out with an extensive, well-documented scientific chart of rates which are actual expenses. And even if we calculate 15% on it, we have submitted this to the government. Here the role of association comes into play. Because one thing is, individual doctor is very strong to a certain extent. But we need to make our association strong. And that will come with the unity of these hospitals. That is why IMA started the Hospital Board of India exclusively to cater the needs of small and medium-sized hospitals. We started the accreditation program. We asked the NABH, worked with it and started accreditation program to improve the quality for small hospitals. The certification program, unfortunately, only 2% of the hospitals in India are accredited. But quality is one area of improvement which we need to do. Association can help in forming, as like what I explained in Kerala, common procurement, common hiring policies, common rates, so we can negotiate better. Say now Star Health Insurance. See, AHPI is one of the organizations of hospitals, but IMA HBA is a much larger body. And now again in Mumbai and in Pune, around 7 years back, the cashless services were totally boycotted. And then which made the insurance companies come to negotiate and then better rates were negotiated. All this are the roles of association. But when the government or policymakers will listen to our association, when our association is strong. And who can make our association strong? We ourselves. If we make our organization strong, a strong organization in turn can help its own members. And one of the critical areas is the survival of the small and medium-sized hospitals. Because if we see, majority, rather 90% of the Indian Medical Association members are private practitioners and who are having small and medium-sized hospitals. So to conclude, small hospitals are vital for ensuring accessible and affordable healthcare in India. Survival requires a blend of strategic innovation, collaboration, technological adoption, and a relentless focus on patient-centric care. Again, I will repeat, this is our trump card. You need, by leveraging their inherent agility and community connections, small hospitals can not only survive, but also thrive in a competitive market. Because we, again, I will repeat, the friendly neighborhood nursing home provides affordable, accessible, 24/7, accountable, accessible healthcare. And if the government or the policymakers think that by promoting corporatization, they are doing a service, they are doing a great disservice to the patient. Today, the general inflation is around 4%. But do you know the inflation for medical cost is 12.7%? Every year, the medical costs are increasing by 12.7%. And this is because there is a rapid corporatization of the private health sector, while the government is slowly trying to come out in building public health infrastructure. Instead of insurance model, government should see to it that government health infrastructure is strengthened and it reaches each and everywhere to provide primary health care. Thank you. Thank you very much. Sorry for the technical issue that I am unable to see, but I can definitely listen for your comments. Thank you.
Thank you very much, sir. Such a wonderful talk. And you really spoke our hearts because we, the private practitioners, are really.
I am somehow unable to hear on this particular thing. I think now I will come on to.
So please come on your phone. Probably you were able to join by phone.
Just a second, Pawan bhai.
Sure, sir. Sure, sir.
Hopefully, I am audible.
Yes, sir. Yes, sir.
Sorry, I was not visible from there. I don't know what has happened.
Sir, a wonderful talk. Really, you spoke our hearts, and you spoke the problems which individual doctors are facing day in and day out for survival of their hospitals. So basically, the threat is from various sectors, be it corporates, be it insurance, and be it government policies. And certainly, regulations are killing the small hospitals because so many compliances are not possible for small hospitals. But definitely, when we have some innovative technique and we have better patient connect, then probably we'll be able better to survive our hospitals. And if there is any question from any of the participants, please unmute yourselves and you can ask directly to Dr. Ravi, sir. Two weeks ago, we also had a webinar on AI, which is available on our YouTube channel, IMA Haryana Academic Fiesta. So you can listen to that webinar and you can also join the journey of artificial intelligence in your practice also, because artificial intelligence is going to stay in our healthcare sector and it is going to replace those doctors who are not taking care of or taking the support of AI. So AI will not basically replace us, but definitely the doctors who use AI and the doctors who are not using AI, they'll be replaced. So AI
Very
should.
true. Very true. As I said, see, there are so many challenges to cover that in such a each one of the challenge can we can have a 1 hour talk and the solutions to it. But as you rightly summed up, government policies, there is a hidden agenda behind it, regulations, multiple regulations, and our insurance based model, survival. And the main key two things is one is a strong organization to fight all this menace and a patient centric approach. I think, and creating subspecialization. If you are an orthopedic hospital, create a niche practice that yes, I will be doing only shoulder arthroscopy. That is going to key to our survival.
Good evening, sir. This is Dr. Dhiren Patel from
Good
Surat.
evening, Dhiren Bhai.
Yes, good evening, sir. I think you have done very good. I know you have given very good information because nowadays it is very important to survive these small hospitals. So I think a very interesting topic and very well covered. Actually, I am asking the important question, like 15-bed hospitals, yeah, 20-bed hospital, the NABH is really required for those all hospitals, like small hospitals. And second question, now government is also planning for ABDM, the registration in this. So is it required to compulsory enroll in that, or what do you suggest?
The government is working on multiple strategies to try to control it. One thing, NABH is a purely voluntary process. What we did, when I was the Hospital Board of India secretary in 14 to 16, we worked closely with NABH and created a very simple module for less than 50 SCOs, small healthcare organizations, less than 50 beds by definition, and started a entry level accreditation program. That is
Right,
why it is very simple. What is the important advantage of NABH is your quality services definitely improves. Simple thing of how to transport a patient within the hospital. Or every month you have to check your own stock and remove outdated injectables. See this one simple thing, if your patient goes in arrest and your adrenaline is expired, that is life and death, and a patient dies because want of particular things. Simple
right,
things, very simple procedures. So importance of quality is definitely there. Second part, government is trying to enroll in Rohini, government is trying to enroll in Clinical Establishment Act. They want to somehow the babus, the bureaucracy always felt that we are under regulated, we are not under their purview.
right.
Now they are नकेल कसना बोलते हैं ना धीरे 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 they are
Yeah,
trying to control us. Here
absolutely
the
right.
role of association comes in a big way.
Correct.
Yes,
Sir,
thank you.
see,
बोलिए.
Thank you, sir.
the government panels are basically they are low cost, and the payments are very low. So here also comes the role of Hospital Board of India, because Hospital Board of India uh, try to give us the cost for uh, every procedure, and there is a big list of which is provided by Hospital Board of India for daycare, for small operations, for big operations, and everything from scratch to the biggest hospital procedure. So we at IMA can press the government on our Hospital Board of India recommended rates, so that these low cost government panels can be really countered by our own costing analysis. And I would request Dr. Ravi on this point.
Very true, absolutely right. Let me give you a bit of background. Uh, as after 2 years of Secretary of Hospital Board of India, where Hospital Board of India started in 2011-12, and it was in a very infant stage. Still, we managed to conduct a clear scientific study, and we presented this study in 2018
फिर बेटा सुनूंगा क्या
2018 to the government, I should mention Ravi Kumar from Coimbatore, who was chairman hospital board. Previously, he was secretary hospital board of India. Tamil Nadu had a very efficient hospital board of their particular state, and all comparative study was given. Now it is up to the state units to enter into a dialogue and to unitedly fight that these are the studies, these are the costing from done from each and every town, as I said, from tier 1 to tier 4 cities for all procedures, all type of hospitals. We have even worked out how much the cost is in government hospitals. The government ICU bed cost 11,000 rupees per day. And it is a irony that the government under Ayushman Bharat wants us to do a cesarean section with drugs, with medicines, and with anesthesia, with food in 12,000 rupees. So here again, role of association is very important.
Hello.
Yes,
Hello.
go ahead, please.
This is Dr. Avinash, sir, from Haryana. Hello.
Go
Sir,
ahead.
I want,
Go ahead, sir. Go ahead, sir. You are audible.
Sir, I want to say one thing that the NABH, it has become must now for, say, if we want to take Haryana government empanelment or any other. So this is a prerequisite. So like my hospital is exclusive ENT hospital. So it is basically 10 bedded hospital. We hardly operate 15 to 20 cases a month. So revenue is that much. So, but for the bylaws for NABH are same for 5 bedded as are for less than 50 bedded. Every year we are supposed to shell out 1,77,000 fee for renewal of NABH. So it is really exploitation of hospitals like ours. Like we are not able to generate that much revenue. Single specialty ENT hospital every year, so much renewal 1,77,000. That is equal for 5 bedded and is equal for 49 bedded or 50 bedded. So it is really injustice. Hospital Board of India needs to look into this because otherwise we are at the verge of extinction.
You
Our
are
hospital will be
absolutely
closed.
right, sir. We have always thought that ophthalmologists and ENT both have similar issues, and to have a separate certification program for daycare hospitals where mainly 5 beds, 10 beds are required, where daycare procedures are done, and such huge amount is not needed. Many a times it is also seen that the agents who say that we will get you accreditation and they charge heavy fees. So definitely this is a very big issue, especially for daycare procedures. I totally agree with you, sir.
Sir, another thing is like this everything we are really under very much stress. Like agent, this we have to hire a consultant. He will say, I will charge 2,50,000 for full NABH. So 2,50,000 shelling out 2,50,000 for that consultant, and then paying for the hire our inspectors will come, assessor will come, paying for their to and fro travels. They are stay in hotel. It is just like passing another PG exam for these small kind of setups. We are really under enormous stress. And
Absolutely right. What Hospital Board of India now needs to do, because now it is 14 years in existence, is to start its own accreditation program. There is no need of any NABH is not a government body. It is a
sir,
part of.
then
Let me complete. I totally agree with the problems which you have said, and we are well aware of it. That is why we are now working on our own accreditation program, which we need to get approved from the government. The entire module is ready, and IMA HBI has now created nearly hundreds of NABH assessors who are our IMA members. For last 4-5 years, we were conducting workshops to create our own NABH assessors who are IMA members, who are IMA activists, and now the entire module to have our own HBI accreditation. Now the issue is only when we can roll it out, and once we roll it out, when around 100, 200 hospitals are accredited by HBI itself, then we can go to the government and say we don't need NABH. This is our peer accreditation program. That is the
Sir.
only solution to it.
Sir, recently I had this entry level NABH already I had. Now I am going for full NABH. So my consultant told me that at the day of inspection, you need to have 10 staff nurse. 10 staff nurse. So, sir, how it is possible?
But why are you going for full accreditation?
Sir, that is important for Haryana government empanelment. That is required for initial 2 years. It will allow for in entry level. Then you have to go for full NABH if you want to take benefit of
Haryana
Haryana.
IMA is very strong and united, which you have demonstrated by boycotting the Ayushman Bharat. Similarly, you work together unitedly and try to remove that clause where NABH, full NABH accreditation is required for government empanelment.
Sir, that is why we are suffering now. All the patients are going to corporate hospital. Our patient flow has drastically reduced.
That is the hidden agenda.
So we are really suffering, and we are at the verge of extinction. Now he says that there should be 3 doctors. NABH says that there should be 3 doctors. I have to show ghost faculty like
full accreditation is a mirage. To chase full accreditation is to create false issues like private medical colleges create, and then it is not only a costly affair infrastructurally from human resource point also. Unnecessarily, the entire thing is nothing but a money extraction event. And as I said, again repeat, there is a hidden agenda which you rightly pointed out, where they want to squeeze out small hospitals.
Sir, that is why
unfortunately, what is happening, one point, let everyone understand this. All the policymakers, may it be the chief minister, may it be the central minister, state ministers, MLAs, all IAS officers, where do they go and take treatment? They go and take treatment in corporate hospitals. Do they come to your small hospital? No, because the entire expenditure is not from their own pocket, it is from the government or from the taxpayers' money. You and I pay taxes, and on that they get treatment in all these big hospitals. And that is why they want to promote such big hospitals. Also, it creates for them that all these hospitals are exploiting. That is why this image that doctors are dacoits and hospitals loot the patient. That is because these opinion makers take treatment from such corporate hospitals. They don't see and what a common man goes to a friendly neighborhood nursing home.
Ravi sir,
yes.
I want to say one thing कि NABH ने ऐसा क्यों बनाया कि हमें गोस्ट फैकल्टी शो करनी पड़ती है उनको. आप एक ENT
वो तो
वाले
आपको NABH को ही पूछना पड़ेगा.
सर वो भी तो आपने ही बनाया हॉस्पिटल
हमने नहीं बनाया NABH. हमने NABH नहीं आपको गलत फहमी है. जब मैंने बोला कि हमने 14-15 में NABH के साथ KK अग्रवाल प्रेसिडेंट जनरल सेक्रेटरी थे, मैं हॉस्पिटल बोर्ड का सेक्रेटरी था. हमने टाइप इसीलिए किया था कि उनका एक्रीडिटेशन प्रोसेस अपने को समझ में आए और छोटे अस्पतालों के लिए एक अलग से, क्योंकि तब सिर्फ फुल एक्रीडिटेशन था. 2015-16 के पहले सिर्फ फुल एक्रीडिटेशन था, वो कि पॉसिबल ही नहीं था किसी को. इसलिए हमने सोचा कि एक एंट्री लेवल एक्रीडिटेशन, उसके बाद सर्टिफिकेशन आया, फिर लैब्स के लिए आया. ये झगड़ा तब से है कि ऑफ्थेल्मोलॉजिस्ट और ENT की डे केयर प्रोसीजर्स में उनको 5 बेड या 10 बेड के लिए अलग से प्रोसीजर चालू एक्रीडिटेशन चालू करना चाहिए NABH में.
ये आपसे रिक्वेस्ट है, आप ये हमारा पॉइंट पहुंचाएं क्योंकि हमारे पास बहुत ज्यादा. सर आप ये बोलते हैं एक RMO रखो, एक RMO, एक मैं खुद ही हूँ, मेरे को RMO की रखने की क्या जरूरत है? एक RMO होना चाहिए और एक वो होना चाहिए. हर जगह झूठ बोल के हमें शो करने पड़ते हैं कि ये हमारा RMO है.
इसलिए मैंने एग्जांपल दिया, प्राइवेट मेडिकल कॉलेज जैसा हो गया है वो.
नहीं सर, एक्चुअली मेरा क्या कहना है उसमें, एक्चुअली जो NABH का है ना, उससे बेटर आपने जो राइटली पॉइंट आउट किया कि जो एक्रीडिटेशन है ना वो प्राइवेट बॉडी है. एक्चुअली गवर्नमेंट का जो अभी जो क्लिनिकल एस्टेब्लिशमेंट एक्ट आया है, राइट, जो अभी मेरे घर में सभी जगह पे हो रहा है, अभी गुजरात में भी अभी दे आर इंट्रोड्यूसिंग. तो बेस्ट पार्ट इज कि IMA HBI जो IMA मेन बॉडी जो सेंट्रल बॉडी है उसके साथ में रह के वो जो बेसिक रिक्वायरमेंट तो टू द लाइक स्मॉल हॉस्पिटल, मीडियम हॉस्पिटल, वॉट एवर, लाइक बिगर हॉस्पिटल, अपने को क्या है कि जो बेसिक रिक्वायरमेंट फॉर हॉस्पिटल, जो ऐसा नहीं कि एक्स्ट्रा चीज जो गलत बतानी पड़े, उससे बेटर ही कि रेगुलरली जो पेशेंट के लिए अच्छा है। जैसे आपने बताया कि राइटली पॉइंट आउट कि जो इंजेक्शन एक्सपायर हुआ है, तो आई थिंक एवरी मंथ दे हैव टू टेक स्टॉक और समथिंग लाइक दैट। तो आपका दैट सजेशन इज रियली वेरी गुड। तो उसी हिसाब से बेसिक क्लिनिकल एस्टेब्लिशमेंट में वी कैन गिव सजेशन की इतनी रिक्वायरमेंट एवरी स्पेशलिटी में, लाइक मेडिसिन में इतना चाहिए, ईएनटी में ऐसा चाहिए, ऑप्थेल में, वॉट एवर इट इज। तो आईएमए मेन बॉडी आईएमए एचबीए के साथ रह के एक प्रॉपर वो बना के एक एक्रीडिटेशन या जो भी बोलते हैं क्लिनिकल एस्टेब्लिशमेंट में इंप्रूवमेंट करके, वही अपने को साथ में रह के पूरी सभी स्मॉलर हॉस्पिटल को जैसे स्ट्रेसफुल रहे, ऐसा जैसे अपने अननेसेसरी एक्सपेंस भी बोलते हैं, जैसे लाख, 1.5 लाख, 2 लाख रुपया हर साल, उससे बेटर है कि मिनिमम फी में हर एक डॉक्टर का हॉस्पिटल का काम बन जाए, उसके साथ में रेगुलेशन भी हो विथ प्रॉपर केयर ऑफ ट्रीटमेंट ऑफ द पेशेंट ऑल्सो। इस टाइप का करे तो जिससे एनएबीएच हर एक को लेना नहीं पड़े, और कुछ अलग तरह से आई थिंक आईएमए एचबीआई कुछ सोच के आईएमए सेंट्रल बॉडी के साथ कुछ करना चाहिए मेरे ख्याल से।
सही धीरेन्द्र भाई, वही आखिरी रास्ता है अपने लिए, और उसके ऊपर काम चालू भी हुआ है। क्योंकि एनएबीएच तो एक बॉडी है, इंटरनेशनली जेस्क्वा है, पहले आईएसओ सर्टिफिकेशन लेते
करेक्ट
थे।
यार।
बम्बई में एक अलग ही, सबसे पहले एनएबीएच के पहले बम्बई में एक प्राइवेट बॉडी थी, जो एनएबीएच का डायरेक्टर एक रिटायर होके उसने चालू किया था। तो आईएमए आईएमए एचक्यू आईएमए एचबीआई मिलके एक्रीडिटेशन का मॉड्यूल, और अपने पास सब, जब मैंने बोला ना 100-200 अपने असेसर तैयार, इसका मतलब उनको एक्रीडिटेशन प्रोसेस क्या होती है ये पता है। अपने को करना बहुत आसान है।
राइट।
चलो।
सर, क्लिनिकल एस्टेब्लिशमेंट एक्ट
सर,
हरियाणा का एक्सपीरियंस बताना चाहूंगा।
अब बोलो।
हरियाणा जब हमारा क्लिनिकल एस्टेब्लिशमेंट एक्ट लागू करने की कोशिश की गवर्नमेंट ने, तो आईएमए हरियाणा ने फाइट किया, एंड वी टुक hospitals less than 50 bedded out of the purview of clinical establishment act. So probably this model can be implemented everywhere, and our IMAs of every state branch should take care of Haryana model, and they should basically stress their governments to implement only Haryana establishment clinical establishment act model only.
बिल्कुल सही है।
दूसरा
तो
दूसरा सर एक इश्यू इंश्योरेंस का भी
एक
काफी सारा
मिनट,
प्रॉब्लम है।
एक मिनट इसके ऊपर धीरेन्द्र भाई, आप ही का परसों ही मैंने हरियाणा के लीडर से वो एक्ट मंगा लिया आपका। और कहीं भी हम जब भाषण करते हैं तब यही बोलते हैं कि उत्तर प्रदेश में, हरियाणा में 50 बेड के नीचे हॉस्पिटल इसके रेगुलेशन के बाहर है। तो हम महाराष्ट्र में भी सेम, लिटरली एक हफ्ता पहले मैंने हरियाणा का एक्ट वापस मंगा लिया, यूपी का एक्ट मंगाया, बिहार का एक्ट मंगाया है। तीनों स्टेट में 50 बेड के नीचे के मॉडल चल रहे हैं। तो हम महाराष्ट्र में भी अभी गवर्नमेंट के साथ निगोशिएशंस में है। उन्होंने 10 बेड से चालू किया है, हम बोल रहे कुछ भी नहीं, हमको 50 बेड के नीचे वाले सब हॉस्पिटल बाहर चाहिए। तो डेफिनेटली हरियाणा मॉडल हमको लाना ही है, और सब स्टेट्स ने यही मॉडल लाना चाहिए।
नहीं
बोलो
अच्छा है,
धीरे।
बहुत अच्छा बात है सब। आप 50 जैसे हरियाणा ने किया, आप महाराष्ट्र में करो, तो फिर हम गुजरात में उसको इंसिस्ट करते हैं।
अरे नहीं, हम तो बोल रहे हैं ना कि 3 बीजेपी रूल स्टेट है, बिहार है, यूपी है, हरियाणा है, तीनों ने
राइट।
किया है। तो यहाँ आपको करने में,
करेक्ट है।
महाराष्ट्र में करने में क्या दिक्कत है, गुजरात में करने में क्या दिक्कत है?
करेक्ट। मेन इश्यू दूसरा सर क्या है कि इंश्योरेंस का भी काफी सारा प्रॉब्लम विद स्मॉल हॉस्पिटल्स, स्मॉल एंड मीडियम हॉस्पिटल। तो इंश्योरेंस का भी कुछ आई थिंक एचबीआई को कुछ एक्टिवली आई थिंक ईडा के साथ कुछ बात करके कुछ आई थिंक ऑल ओवर इंडिया में कुछ करना चाहिए। बिकॉज नाउ डेज जो छोटी कंपनियां हैं जो अभी लाइक जो प्रीमियम भर के करती है, लाइक वो छोटा छोटा अट्रैक्ट करके एजेंट के साथ, लेकिन वो बाद में क्या है क्लेम देने में बहुत दिक्कत करती है, और दे आर गिविंग वेरी नॉनसेंस रीजन। सो आई थिंक उसके
आपको
लिए कुछ
धीरेन्द्र
करना
भाई
पड़ेगा।
आपके संज्ञान में ला दूं इंश्योरेंस पे, फिर बोलेगे यार रवि भाई आप ही बोल रहे हो। जब मैं नेशनल प्रेसिडेंट था 2018 में, सबसे पहले हेल्थ इंश्योरेंस समिट किया अपन ने दिल्ली में, फर्स्ट हेल्थ इंश्योरेंस समिट। उसके बाद 4 हुए पिछले 6 सालों में, जिसमें इंश्योरेंस कंपनीज, टीपीएस, पेशेंट ग्रुप्स और हेल्थ केयर प्रोवाइडर्स की पूरी 2 दिन की समिट लिया। उसके बाद अपन आईआरडीए हैदराबाद में जो बॉडी है, उसका एक हेल्थ इंश्योरेंस की अलग से उनकी सब बॉडी है। उसमें आपको जान के खुशी होगी कि आईएमए एचबीआई का एक रिप्रेजेंटेटिव तब से अपन ने वो बॉडी में इनकॉर्पोरेट करने के लिए लगाया, और तब से कंटिन्यूअसली पिछले 5 साल IMA हेडक्वार्टर से एक बंदा नॉमिनेट होता है IRDA में हैदराबाद में, हेल्थ बॉडी पे, हेल्थ इंश्योरेंस के बॉडी पे।
अच्छी बात
तो
है यार।
हाँ, तो ये चालू है। क्या होता है ना कि ये सब चीजें परकोलेट होने को भी टाइम लगता है। आज बात निकली तो मैंने बात किया, खुद होके तो अपन सामने से बताते नहीं है। तो ये हेल्थ इंश्योरेंस पे अभी भी यानी 4 समिट हुई उस 6 साल में। हर 2 साल में एक समिट कर रहे हैं अपन, जहाँ की सब लोगों को इकट्ठा कर रहे हैं। प्रॉब्लम्स इतने इंश्योरेंस के,
बहुत सारे
जैसे
यहाँ सर।
मैं तो इंश्योरेंस पे 1 घंटा बात कर सकता हूँ, मैं पूरा
या
स्टडी किया हूँ। ये
सर
इंश्योरेंस
इंश्योरेंस में
बेस्ड मॉडल खराब मॉडल है।
सर
एब्सोल्युटली या
इंश्योरेंस में एम्पेनलमेंट कराने से लेकर के और
सभी सभी
बिल पे करने तक हर लेवल पे भयंकर करप्शन है सर, भयंकर करप्शन।
भाई साहब, मैं आपको बोलूं, उसमें जो लोग रहते हैं ना, उनको एक इंस्ट्रक्शन रहता है, ब्लैंकेटली बिगर देके 15% फॉर्म्स क्लेम्स रिजेक्ट कर दो।
बिल्कुल
यानी
सर मैं
इतना बेकार है, क्योंकि जैसे मैंने समझाया ना, दे आर फॉर प्रॉफिट ऑर्गेनाइजेशन। 30% प्रॉफिट है हर साल हेल्थ इंश्योरेंस कंपनी का एवरेज। वो प्रॉफिट कहाँ से आएगा? एक तो हॉस्पिटल को कम पैसे पे कराने को लगाओ, और नहीं तो पेशेंट के क्लेम रिजेक्ट करते रहो। उसके सिवा पैसा बनेगा कहाँ से उनका? और
बिल्कुल सही बात है।
गवर्नमेंट पागल है, गवर्नमेंट इंश्योरेंस कंपनी के थ्रू गवर्नमेंट मेडिकल कॉलेज, गवर्नमेंट हॉस्पिटल्स को पैसा दे रही है।
सर, उनका तो मॉडल है 3D मॉडल, डिले, डिस्प्यूट एंड डिनाई।
हाँ, तो उसकी बेसिक है ना,
ये
पैसा
सही
कमाना
बोला
है।
आपने।
सर एक बात बोलना चाहूंगा। सर बोल सकता
बोलिए,
हूँ?
बोलिए, बोलो।
सर देखिए, अभी क्या है कि हरियाणा गवर्नमेंट एम्पेनलमेंट का एक प्रोसीजर है। उसमें ये है कि सबसे पहले तो आपको आयुष्मान आयुष्मान पैनल पे होना चाहिए हॉस्पिटल को, उनका क्राइटेरिया है। अभी दूसरा उनका क्राइटेरिया ये है कि इनकम टैक्स डिपार्टमेंट से भी आपको एग्जेम्पशन सेक्शन 17(2)(b) के तहत लेनी होगी, तभी आप वो, उसके लिए अभी क्या हुआ, इनकम टैक्स की एक टीम आई, उनके इंस्पेक्टर, उनके वो सब, दे इंस्पेक्टेड माई हॉस्पिटल। अभी इट इज स्ट्रेंज कि एक नॉन मेडिको IAS ऑफिसर एंड देयर 5 पीपल आर कमिंग टू ए हॉस्पिटल टू गिव, क्योंकि मेरे को उनसे परमिशन चाहिए कि वो इनकम टैक्स एग्जम्पशन के लिए दिस हॉस्पिटल इज फिट। तो हाउ मैनी पीपल विल इंस्पेक्ट? हम छोटे छोटे हॉस्पिटल वाले कितने लोगों की उससे एक्सप्लॉइटेशन होगी, हमारे से कितने लोग हमें एक्सप्लॉइट करते रहेंगे? हमारी IMA बोलती क्यों नहीं है, हरियाणा की IMA की ये क्लॉज आप हटाएं उसको वहां से। हॉस्पिटल का क्या, एक रेवेन्यू ऑफिसर, उनके 5-6 क्लरिकल स्टाफ आगे एक हॉस्पिटल का इंस्पेक्शन करेंगे, ये देखेंगे कि ये OT सही है, ये इनका OPD सही है। हाउ हाउ मच दे आर अवेयर ऑफ द मेडिकल फैक्ट्स एंड दिस थिंग? ये क्लॉज व्हाई डोंट दे रिमूव दिस क्लॉज फ्रॉम द दिस थिंग, कि अप्लाई करने के लिए ये मस्ट क्यों है हरियाणा गवर्नमेंट अप्लाई करने के लिए? व्हाई आवर हरियाणा IMA इज मम ऑन दिस?
IMA Haryana is not mum on this. We have taken up this issue with the government कि जो income tax exemption certificate है, इस पे we are working and probably we will get the result very soon. Dr. Avinash, for your information.
हाँ सर, लेकिन इट इज रियली बहुत हैरासमेंट फील होती है सर कि हमारे छोटे
Okay,
छोटे
we have
हॉस्पिटल।
taken up this issue with the government, and there is one Dr. Rakshit Agrawal who was raised hand. Dr. Rakshit, if you are there, please unmute yourself and ask the question.
Yeah, yeah. Good evening, sir. I am a general surgeon based in Sirsa. सर एक ये ETP प्लांट का बहुत इशू है सर, लाइक ETP
STP
प्लांट।
प्लांट का।
हाँ सर, ETP और STP दोनों ही सर, मतलब ये कितने बेड्स पे कंपलसरी कर रखा है इन्होंने। अब जब भी हमको पोल्यूशन सर्टिफिकेट लेना पड़ता है, बहुत ज़्यादा करप्शन है सर, जो CTO सर्टिफिकेट्स या इन सर्टिफिकेट्स के लिए।
बायोमेडिकल वेस्ट का इश्यूज बहुत सारा है। 2-3 छोटे छोटे सक्सेसेस मिले हैं। STP प्लांट, जो भी कारपोरेशन, जो भी शहर में, अगर आपकी कारपोरेशन, आपकी म्युनिसिपैलिटी का अगर सुएज कलेक्शन है, तो आप 50 बेड के नीचे के हॉस्पिटल को उसका आपका सुएज उसको ज्वाइन कर सकते हैं। तब जाके आपको STP प्लांट की जरूरत नहीं है। समझ में आया एक बात?
हाँ ठीक है सर।
तो जहां जहां कारपोरेशन का अपना खुद का सुएज नेटवर्क है और उनका सुएज ट्रीटमेंट प्लांट है, जनरल
हाँ
यानी
हाँ
आम
हाँ
जनता का जो होता है।
सर, एफ्लुएंट ट्रीटमेंट प्लांट ETP का
हाँ,
भी कुछ।
हाँ, वही।
अच्छा।
तो उसको अपन कनेक्ट कर सकते हैं। वो सूरत में अपने को एसटीपी लगाने की जरूरत नहीं।
सर ये हरियाणा में तो
अरे ये सेंट्रल गवर्नमेंट का रूल है।
2018 में वी मेट विद आवर एनवायरनमेंट मिनिस्टर मिस्टर भूपेंद्र यादव along with IMA secretary president and the hospital board of India chairman,
हाँ
and
जी सर।
there we got this basically recommendation that
मैं भी था।
बताया कि जहां जहां भी सेंट्रल ट्रीटमेंट प्लांट है कॉरपोरेशन का, वहां 100 बेड से नीचे आपको ईटीपी एसटीपी लगाने की जरूरत नहीं है। और आप वो जो है ये रेगुलेशन उनको बता सकते हैं, अपने जो आपका रीजनल पॉल्यूशन ऑफिसर है
हाँ जी
उसको,
हाँ जी।
और ही हैज टू कंप्लाई टू इट। अदरवाइज इसका जो है ना आपको लेटर डॉक्टर अजय महाजन से मिल जाएगा, बिकॉज
ठीक है।
डॉक्टर अजय एंड वी वर देयर इन दैट मीटिंग।
बिल्कुल, भूपेंद्र यादव साहब को हम 2 बार मिले। उसके बाद उन्होंने वो सेक्रेटरी के, साउथ इंडियन था सेक्रेटरी, वो साला बड़ा टेढ़ा था, जल्दी मान नहीं रहा था। अच्छा, आप और डॉक्टर साहब सिरसा से हो, आपका नाम क्या है? वो हमारा एक स्टूडेंट है वहाँ, सुदीप, ईएनटी
हाँ हाँ
सर्जन।
हाँ 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 सर, मेरे कलीग ही हैं डॉक्टर सुदीप मुंजाल।
सुदीप को नमस्ते बोलना यार, वो अपना खास
जरूर
बच्चा
सर,
है।
जरूर सर, जरूर सर, जरूर सर। बहुत अच्छा कर रहे हैं सिरसा में, इज डूइंग वेरी
हाँ
गुड।
पता है, वो और उसकी बीबी
हाँ
दोनों
हाँ
मेरे
हाँ।
स्टूडेंट है, दुलिया के
अच्छा
मेडिकल कॉलेज के हैं।
अच्छा अच्छा अच्छा। ठीक है
Any
ठीक है।
other question from anybody else?
Hello,
सर,
good evening, sir.
गुड इवनिंग।
Sir, I'm Dr. Vivek Mukhmale, sir. Actually, I'm Maharashtrian, but I'm working right now in near Bangalore. In actually, I'm talking from right now in Karnataka. Hello,
गो
sir.
अहेड।
I'm audible. Sir. So I'm a neurosurgeon. Last 1.5 years, I'm working for one corporate hospital. So what you said in your talk, that is very actually, I am very thankful for IMA Haryana and Ravi Wankhedkar sir for giving such an informative and valuable talk. Actually, I am planning to start my own hospitals because right now what I'm facing issue ki because of me corporate hospital earning in crores every month, my hospital is revenue they are generating around 80-90 lakhs or 1 crore. What they are paying me almost 2.5 to 3, and everything, pensions, everything, it will be on my head. So, lastly, it's my wish also. Okay, I should start our own hospital so that it should be beneficial for the patient also. So let me give a valuable advice, sir, ki what perspective I should think before starting
Girls,
hospitals.
all the younger people who want to start their hospital have a combined joint practice.
Okay, sir.
This is the solution of future, that now we doctors should come together, keeping our egos. We doctors have big egos. I am very
Mhm.
honest and blunt about it. We need to keep our egos aside and to have now combined or joint practice. 4 5 consultants coming together, sharing resources. That also helps in sharing the physical and mental work also, and that model now is being successful in now most of the tier 3, tier 4, tier 2 cities, where 8 consultants, 9 consultants, say, I can give example of obstetricians coming together, 3 4 obstetricians coming together and starting a maternity home, where each one works on 8 hour shift. So everybody
Mhm.
gets, so even their assistant for major surgery is taken care of, OPDs are taken care of, pediatricians coming together and starting neonatal or pediatric ICUs. This is a trend which has picked up tremendously in Maharashtra. Now each district is having 2 3 such ICUs, where now pediatricians don't admit in their own hospitals. They run OPDs or do day admissions, and if they need for admissions, they send that to their common facilities. So you will have to think in terms of
No, sir. Yes, sir. Yes, sir. Yes, sir.
finding good partners where invest, because investment is also a big burden, friend. And
Yes, sir.
one investment is a burden. You take a loan, then by hook or crook, even if 10 patient comes or 100 patient comes, you need to earn a quantum that my 10 lakh rupees is going to the bank. So I need to earn 10 lakh rupees from either 10 patients or 100 patients. So
Yes, sir.
combine effort.
And
Sir.
anyhow, neurosurgery means it will require teamwork, sir. Anesthetic,
Yes, that
ICU
more so ever. And as you rightly said, super specialists are the most exploited class by the corporate
Yes, sir.
hospitals. The average doctor, super specialist gets maximum 20% of the entire hospital bill in a
Yes,
corporate
sir.
hospital. May it be cardiologist, cardiac surgeon, or neurosurgeon. These are exploiting.
Dr. Karan Punia, sir. He has raised his hand. Dr.
हाँ, हाय करण.
Hi,
आपका
sir. How are you?
चेहरा दिखाओ करण. अच्छा,
Yes,
बोलिए
yes.
बोलिए करण जी.
सर मैं यूं कह रहा था, आपका इतना बढ़िया लेक्चर था, मैं तो मंत्रमुग्ध हो रहा था. You still have got the same fighting spirit as you had in 2018. Salute to you. Very good, in fact.
थैंक
सर
यू.
ये IMA ने जो एसएसएस तैयार किए हैं 200, 150, 200,
हाँ
तो ये NABH बाउंड है क्या उनको भेजने के लिए?
हाँ बिल्कुल. एनएबीएच के कहाँ ऐसे सर थे? 14-15 में 10-12 लोग थे सिर्फ एनएबीएच के पास. ये तो अभी बहुत है. अपने सैनी साहब ने कई प्रोग्राम करे, जॉइंट प्रोग्राम्स, कई एसेसर्स बनवा लिए. शायद नरेंद्र सैनी साहब के पास उनकी लिस्ट भी होगी जो ट्रेन हो गए.
वो तो लिस्ट तो है सर. अभी आपका ही प्रोक्टोलॉजी का डॉक्टर संजय सिंह है मेरे भिवानी में. आई थिंक यू मस्ट बी नोइंग ईच अदर. अच्छा है.
हाँ
उसका असेसमेंट अभी आ रहा है.
अच्छा.
तो उसके अंदर मैंने कहा भी बताना कौन कौन आएंगे. पहले तो एक बार तो शरद अग्रवाल आया था, वो तो मैंने काम बनवा दिया था.
हाँ
लेकिन अभी IMA की तरफ से तो नहीं आते वो वाले, अपने वाले तो.
नहीं, वो तो देखो, आइडियली वो कॉन्फिडेंशियल होता है कि किसको भेजना चाहिए.
लेकिन हमें तो पता होना शहर में, पता होता है कौन आता है. लेकिन
हाँ तो
IMA की
बस वो जैसे पता चल गया तो उसका कांटेक्ट तो निकल ही जाता है. और
नहीं, वो तो
आईएमए ने इसलिए ट्रेन की है कि भाई जैसे रवि वानखेड़कर या जैसे आपने बताया कि शरद भाई आए, तो वो ऑब्वियसली आईएमए वालों को हेल्प करने वाले हैं.
लेकिन बहुत कम आते हैं सर, दूसरे लोग ही आते हैं. आई डोंट नो भाई.
हाँ, क्योंकि
ये जो
ये जो प्री और पैराक्लिनिकल वाले खाली बैठे रहते हैं ना, या गवर्नमेंट ऑफिस वाले, अपने प्राइवेट प्रैक्टिस वाले प्रैक्टिस छोड़ के जाने को कम ही मानते हैं. ये देखा है, पैथोलॉजिस्ट बहुत सारे एसेसर्स बन गए हैं. कई सारे 10-12 तो पैथोलॉजिस्ट को मैं ही जानता हूँ महाराष्ट्र से जो एसेसर बन गए. एनेस्थेटिस्ट बन गए एसेसर्स. लेकिन सर्जिकल ब्रांच, मेडिकल फिजिशियंस ये कम बने हैं. छोड़ के जाना मुश्किल होता है 2-4 दिन.
ओके ओके ओके. ये अविनाश जो बोल रहे थे ना, ये
हाँ
वाकई बहुत बड़ी तकलीफ है और
हाँ,
बड़ा खर्चा है.
बहुत
ये
बहुत बेकार है वो.
बहुत ही ज्यादा तकलीफ है मतलब. और ये हो रहा है, अभी भी हो
ये
रहा है.
अपने को खुद ही का एक्रीडिशन चालू करना चाहिए.
सर
गवर्नमेंट
मैं एक
मानेगी?
बात,
बिल्कुल
गवर्नमेंट
मानेगी, क्यों नहीं मानेगी. अरे अगर अपन 100 हॉस्पिटल एक्रीडिटेशन कर दिए और बता दिया कि एनएबीएच के कितने एक्रीडिटेशन है, 1200 के करीब हॉस्पिटल एक्रीडिटेड है इंडिया में. अपन 200 भी एक्रीडेट नहीं करा सकेंगे क्या अपने आप से? अपन अगर इजी प्रोसीजर करेंगे तो 100 की जगह 500 हॉस्पिटल एक्रीडेट करा के गवर्नमेंट के पास जा सकते हैं कि हम ही खुद ही एक्रीडेट करा लिए हैं और हमारा इंडिपेंडेंट प्रोसेस है. सी, आखिर गवर्नमेंट को कोई भी परीक्षा की, जैसे कि भाई ये इसका सिलेबस यानी मॉड्यूल ये सही है, इसको हम इंडिपेंडेंटली एसेस करते हैं, इसके पैरामीटर्स नेशनल इंटरनेशनल स्टैंडर्ड के हैं, तो अपने आप गवर्नमेंट को एक्सेप्ट करना ही है. यहाँ तो रोल एसोसिएशन का आता है ना कि अपन प्रेशर बना सकते हैं कि हम ये नहीं करेंगे, हमको ये करना है.
किसी स्टेट में हो रहा है ऐसा हमारा?
ऐसा नहीं हो रहा है ना.
फिर फायदा क्या इस बात का?
नहीं सर, करने की प्लानिंग है. इट इज अंडर पाइपलाइन. अभी जैसे ना IMA AMR के स्मार्ट हॉस्पिटल्स का भी प्रोजेक्ट चल रहा है.
हाँ, नरेंद्र सैनी
हाँ,
साहब भी कर रहे हैं.
हाँ, उसका भी सर मैं मेंबर हूँ IMA नेशनल बॉडी का, AMR कमेटी का. तो
सर
हम उसमें भी एक्रेडिटेशन कर रहे हैं. तो उसकी भी ग्रेजुअली सर, जब हमारे नंबर ऑफ हॉस्पिटल्स बढ़ेंगे एक्रेडिटेड,
एग्जैक्टली
तभी हमारी एक्सेप्टेंस बढ़ेगी सर.
एग्जैक्टली.
क्योंकि हमारी एक्सेप्टेंस तभी होगी सर जब हम कुछ करके दिखाएंगे.
सर पाइपलाइन के बारे में मैं समझ रहा हूँ. मैं जो कह रहा हूँ वही कह रहा हूँ कि गवर्नमेंट वो मानती नहीं, उस बात को मान नहीं रही। वन
अरे
थिंग,
मनवा लेंगे, गवर्नमेंट तो कोई भी चीज को मानेंगी नहीं, फिर अपन धंधा किस लिए? धंधा के सिवा गवर्नमेंट मानेगी नहीं, ये समझ लो आप।
सर सर
मैं
एक बात
बहुत
बोल
क्लियर
सकता हूँ?
हूँ। IMA ने
जी सर।
ट्रेड यूनियन जैसे काम नहीं किया ना, ए भाई हाँ गवर्नमेंट हमारी है, ये हमारे है, ये हमारे पार्टी के लोग है, ऐसा काम नहीं बनने वाला है। डंडे के सिवा काम नहीं चलता गवर्नमेंट में।
सर
एक्चुअली
माफ
जैसे
करना।
डिस्ट्रिक्ट, एक मिनट प्लीज, 1 मिनट। डिस्ट्रिक्ट नेग्लिजेंस बोर्ड में हमारे IMA को मेरे टाइम में मैंने फाइट किया था वी साहब से कि हमारा हर मीटिंग की हमारा सहयोग लेना चाहते हो कोरोना टाइम में, तो हमारा एक मेंबर होना चाहिए हर मीटिंग में, हर मतलब बोर्ड जो गवर्नमेंट की तरफ से आता है। एंड वो चल रहा है, आई डोंट वांट टू टेक क्रेडिट, लेकिन हमने ये मुद्दा उठाया और उन्होंने तुरंत उसमें उनको ऑर्डर कर दिया। अब डिस्ट्रिक्ट नेग्लिजेंस बोर्ड में आयुष वालों ने उठाया कि हमारा एक बंदा होना चाहिए। आयुष वाले, BMS वाले अनपढ़ लोग वहां गए, एलोपैथी के बोर्ड में वो आते हैं। एक तो वो, दूसरा जब भी हमारे डिस्ट्रिक्ट नेग्लिजेंस बोर्ड से हमारे बंदे करीब 99% लोग नेग्लिजेंट नहीं पाए जाते, और लोग वहां उसको बड़ी सख्ती निगाह देखते हैं, चैलेंज करते हैं, कभी उठा के मेडिकल कॉलेज में शिफ्ट कराते हैं, कभी कोर्ट में जा खड़े होते हैं। दिस इज द प्रॉब्लम। तो अपने एसएससी वाले के लिए अपने को करना चाहिए, क्योंकि बहुत दुखी हो रहे हैं। अविनाश का दुख कम नहीं है, मैं समझ रहा हूँ उसका
बिल्कुल
दुख बिल्कुल
बिल्कुल
सही है।
सही है, बिल्कुल सही है ये बात।
सर एक बात बोलूं?
बोलो
सर
बोलो।
जी जी।
सर मैं ये कह रहा हूँ, अब जैसे मेरा सिंगल स्पेशलिटी ENT हॉस्पिटल है, अभी क्या है, मैं कहता हूँ CGHS का, क्योंकि सब जगह जितने भी कॉर्पोरेट खुल गए सबके पास CGHS, ECHS, ESI ये सब पैनल है। अभी मेरे को, मैं बोलता हूँ मैंने पैनल कराना है, तो बोलता है एजेंट, बोलता है 10 लाख दो ECHS के लिए, CGHS के लिए 5 लाख दो। सर मैं मर जाऊंगा क्या? आप बताओ। और सारे पेशेंट जाते हैं CGHS, ECHS, ESI, और दूसरा वो कहता है एजेंट के बगैर, वो HDFC एर्गो वाला कहता है 60,000 तो मैं आपका HDFC का करा लाता हूँ।
मैं
वो
तो
कहता है स्टार वाला कहता है 2.5 लाख दो मैं आपका ये करा लाता हूँ। सर मैं क्या करूंगा आप बताओ?
सुबह सुबह घूमना चालू करो खाली पेट,
हैं जी सर?
सुबह सुबह खाली पेट घूमना चालू करो, मॉर्निंग वॉक।
सर यही हो जाएगा। मेरे को तो लगता है कि हॉस्पिटल बंद करके मैं बिल्डर बन जाता तो बढ़िया था। खूब खूब कोठियां बेचता, पॉलिटिशियन से वो करता, थोड़ी उनको पहुंचाता, और खुद खूब बिल्डिंगें बेचता, अच्छी कमाई करता और मस्ती करता। गलत
रवि
डॉक्टर
सर,
बन गया।
रवि सर प्लीज गिव सम सोलेस टू हिम, ये बड़े दुखी है अविनाश।